where we left off yesterday. So we'll go on to the nerves. So let's start with the ulnar nerve. At the level of the elbow, it's really contained in the cubital tunnel. The floor of the cubital tunnel is the medial capsule and the ulnar collateral ligament. The roof is the retinaculum, the flexor carpi ulnaris aponeurosis. Now, the type of constraints to the cubital tunnel have been characterized as the 4 different types. The type 0 means there's no overlying roof, and you can easily get ulnar nerve dislocation, and you can get a frictional neuritis within the ulnar nerve with motion. Type 1A is a thin retinaculum overlying the roof. It's taut and full flexion, and that's normal. A type 1B is thickened, and it becomes taut short of full flexion, which means you can get dynamic compression of the nerve with flexion and extension. And then there's a type 2, which is replacement of the Cutaneous epitrochlearis muscle, or replaced the retinaculum by the abnormal Cutaneous epitrochlearis muscle, and this can produce a static ulnar nerve compression. So, Ashu, what do you think of this case?
35-year-old MLB reliever with medial elbow pain. I think there's medial subluxation of the ulnar nerve, and I don't see a retinaculum.
Right. So that's right in there.
How common is a subluxation of the ulnar nerve?
I'm guessing it's not that uncommon.
Well, give me a number.
10%.
16.5. Now, how they come up with 0.5, I don't know, but that's kind of tricky.
How did they determine?
Anyways, I was surprised when I read Campbell's this today. And
did they determine that at surgery? Is that how they determined it, John?
They just determined it. I really didn't get into it real deep, John.
Okay, because
I just was glancing through it.
By MR, we don't see it displaced that often, but then by MR, most of the time we're not stressing it. So it still may be unstable. We just may not see the instability by MR.
Well, when they say it in Campbell's, they usually mean that something surgical may have happened to it.
Right.
They talk about scarring, etc. But subluxation is a fairly common condition. Obviously, subluxation will cause scarring with time.
All right, so here we can see some thickening and increased signal intensity within the ulnar nerve at the level of the cubital tunnel. Yeah.
Look at this, we don't really see a good
retinaculum. Well, that's a disloc. Oh, wait. Oh, sorry, I didn't mean to say that.
Okay. Okay. Michael?
Okay, so I think that's the ulnar nerve right there in the cubital tunnel. It's a little bit, kind of out medially, but it doesn't really, it looks kind of normal in signal and morphology, at least on the axial image. But it's kind of perched on the humerus a little bit.
Medially subluxed here. Should be right in this location. It's medially subluxed. We don't see a good retinaculum overlying it. Now, the sagittal images I also think are useful. I always try to look at it in the sagittal images. And it's not really swollen here. This may be a little bit of edema, but we see that so commonly in asymptomatic elbows when we did a study of asymptomatic elbows that I don't think that's definitely an abnormal. So this is another, but this patient was symptomatic, and this was another type 0 with probably ulnar neuritis secondary to instability. Ashu?
Here I think it looks like there is a flexor retinaculum there, and I do see a normal ulnar nerve. Maybe there's some scar tissue superficially, but it looks normal. Maybe, okay.
Yeah, so this is a type 1 kind of normal appearance. The nerve is a little bit plump, but that's certainly within normal limits, and that's a normal retinaculum overlying it. If we follow the ulnar nerve proximally, we can start up. Here we can see it medially to the triceps, and you can follow it down. And this case, you can see the ulnar nerve in the cubital tunnel. There is a retinaculum overlying it, but it's clearly enlarged in this particular patient. And then distally, we can see it also enlarged with increased signal intensity on the T2 weighted image. On the coronal stir, we can see it's thickened with increased signal intensity. And this was a patient with ulnar neuritis of unknown etiology. I think in this location, these are usually due to some form of trauma.
Okay. Well, it looks like here on the axial images of the elbow, I can see the ulnar nerve, and it's not displaced, and I don't see any significant edema, but yeah, here on the sagittals, yeah, I'm not sure. It's maybe perhaps some mild increased signal. I don't.
So normally the retinaculum is a very thin structure. It's hard to decide whether it's a type 0 or a type 1A. This one is a lot thickened, so this would kind of be a type 1B, a little bit thickened, but kind of on the borderline between normal and abnormal. And this
Is that a little bit of an hourglass if you go distal?
The nerve, I think, is coming in and out of the plane a little bit here. I don't think it's an hourglass configuration, John.
Okay.
It's a little bit more thickened here on the next, on one cut over. And now here's another case here. Here we can see a clearly thickened retinaculum here. There's the ulnar nerve on a T2 weighted image below it, and this would be a type 1B. Here's from John Reeder from Australia. And here we can see an hourglass configuration with ultrasound where we have high resolution. We can see it's swollen here. We can see it's narrowed down through in this area. And he believed that he saw a fibrous band right here, which was causing the compression and the ulnar neuritis using ultrasound. All right, Phil, what do you think of this?
So on this one, we see that we have an accessory muscle. The accessory, but the ulnar nerve itself looks intact and normal, or like normal in thickness and signal, I believe.
So this is Cutaneous Entrapment here.
Yeah, it's that muscle that's the problem.
So proximally you can see a muscle here, and distally you can see a muscle there, but right at the level, at the joint space, you really shouldn't see a muscle in this location. And here, this is actually a very prominent one. And as stated before, you can get a dynamic compression of the ulnar nerve due to this. And it would be a type 2.
John, it probably doesn't compress unless one flexes the hand or wrist.
Right, but the injury to the ulnar nerve in the literature is described as a dynamic compression causing the ulnar nerve.
Yeah, well, that's a dynamic compression when you say flexing fingers and wrist.
Yep. Ashley, what do you think of this one?
Here we can see an accessory Cutaneous epitrochlearis, and you see increased signal within the nerve itself, and there's also some soft tissue edema there, so might be worried about some ulnar neuritis.
What about the coronal nerve images?
Here on the coronals, well, on the Is that the stir sequence? I see increased signal, yeah, within the ulnar nerve itself. So,
And notice it's thickened and edematous proximally, and then
and
it's
flattened.
normal, more normal appearance distally, and this is right at the level of the compression right here. Okay, good. Is it yours? Do you have a question?
Okay, so this is a 52-year-old with lateral hand numbness. It looks like there is some increased signal. Yeah, was that the same case? Okay, so this is the lateral.
Apologize. It's just the sagittal images showing it. Okay, here.
So 40 years old with elbow pain for 2 years and wrist weakness. Yeah, I don't see the ulnar nerve very well. It may be increased signal and slight laterally subluxed. Yeah, there's some edema, and I see a large osteophyte, probably causing some friction injury, and yeah, definitely some degenerative disease. So prominent osteophytes near the ulnar nerve. The distal images. Okay. So we see. Okay, just preferential muscle edema in the flexor digitorum profundus.
This is more atrophy than just edema. There's some edema. Notice how sharply defined the edges of the fluid is here, and this is what you see in carpal tunnel syndrome. So here the patient has had compression of the nerve with a lot of neuropathy due to these large osteophytes, and over time is what's happened is that's called neuropathic damage to the muscle that it innervates here, and you're getting chronic atrophy and some degree of edema.
Well, it's putting it under tension by pushing outward.
Okay. Yeah.
And obviously it's rubbing on it. And I suspect every time the guy leans on a table or something, he's gets
right.
Squeezed.
So carpal tunnel syndrome has to do with neuropathy due to damage to the ulnar nerve, typically at the cubital tunnel area, and typically in the more acute phases, you'll see edema in the flexor carpiulnaris and digitorum profundus muscles that it innervates, and then over time these will become atrophic. So that's what you look for in looking for acute and chronic carpal tunnel syndrome.
So is the kind of large tubular structure, is that the ulnar nerve? Because if it is, it's pretty thickened and edematous. Yeah, so on this one it doesn't look as big on the axials, but it still looks a little irregular and thickened or edematous. But I don't see, the retinaculum's intact. And there's a lot of tissue. Yeah, like surrounding it. Well, I mean, I assume there's neuritis, but I'm not. Is there something specific you're asking about, or?
This was an
Hamartoma.
Producing cubital tunnel syndrome. Okay. Ashley, what do you think of this case?
Just looking at this, I don't know if seems to be a lot of scar tissue along the medial aspect of the elbow, or some fibrosis there. Yeah, I don't know if that's a displaced ulnar nerve or it's just a thickened ulnar nerve there.
There's the ulnar.
Oh, it's flattened. Okay, so the ulnar nerve's, yeah, so that one's flattened and there's some scar tissue. Okay.
Yeah, and there you can see the scar tissue on the others. And this was ulnar neuropathy after trauma with scar tissue here. I don't know whether it's the scar tissue that actually caused the neuropathy or trauma and impaction of the nerve which caused the neuropathy and also damaged the surrounding soft tissues, causing scarring in this particular case. But the patient did have cubital tunnel syndrome associated with this. And
A funny bone is a misnomer.
it's not so funny.
It's not funny.
Okay, so here I don't see the ulnar nerve in the cubital tunnel. It looks like there might be some anterior subluxation. No?
So if we start up high, here's the
Okay.
ulnar. Go down here. There's the ulnar.
There it is.
There's the ulnar. There's the.
Yeah. So I guess it's
That might even be considered as a dislocation.
location. Yes.
The Campbell's kind of lumps them together.
Yeah.
So, and this is, what do you think happened here?
Well, the flexor retinaculum is irregular, and there's some soft tissue thickening. So I'm thinking they have a tear, chronic tearing of the flexor retinaculum, and maybe it's dislocating and relocating.
The treatment for ulnar neuropathy, if it's refractory, is relocation of the nerve anterior to the condyle. And so this is surgical scarring here. This is someone who had surgery, and they moved the nerve anterior to the condyle to decompress it. So that this is someone who had surgical treatment for the condition. And this is what they used to do all the time in Tommy John's, but only rarely.
Okay, so I assume that's the ulnar nerve we're looking at, that linear, on the stir, that linear bright structure. And if that is the ulnar nerve, it's going to be at least, it's subluxed out of the cubital tunnel at that position. It's kind of too medial.
Okay. Actually, this is anterior too.
Yeah.
This was another condition. Aishu?
This is my turn?
Yep.
Okay. I think I see the ulnar nerve anteriorly outside of the cubital tunnel. I think this is another repositioned.
Yeah. And this one I just want to show all the scar tissue that can develop around it, which is one of the complications you can get. And the scar tissue can adhere to the nerve itself, and then it can retract, distorting the nerve and actually producing a neuropathy. It's one of the complications of surgery and transposition of the ulnar nerve.
Where's the surgical scar, John?
This is surgical scar all back here.
Right there?
Yeah.
And that's what I figured.
Stuff in here.
But what they do is they almost make it a U kind of scar with a convexity posterior.
Okay.
And then they take the flap of skin and move it anterior out of the way, and then there are all kinds of little tricks that are used depending on who the surgeon is.
Okay. Thank you. And here's a patient who had recurrent symptoms. Here we can see a big thickened ulnar nerve with a lot of scar tissue, dense scar tissue around the ulnar nerve. Here the axial plane. Again, we can see a transposed ulnar nerve, markedly thickened, and a little bit of edematous, and this really thick scar tissue encasing the nerve, which we can see there. And that was all scarring. Okay. Well, let's move on to the median nerve. It comes down by the supracondylar process up and through here. Then it goes by the pronator muscle, in which case if you have compression here, it gives you the pronator syndrome. Then it goes distally and becomes the anterior interosseous nerve, and there's an AIN or anterior interosseous nerve syndrome that can be associated with compression in this location. And then distally, we can get compression in the carpal tunnel and get carpal tunnel syndrome. So there's a list of different ones. So let's start with the supracondylar process proximally. It's a congenital anomaly in humans. It's at the attachment of the ligamentum of Struthers, typically diagnosed on plain films. and if you have problems in this location, you get symptoms throughout the forearm because it would be in the distribution of the median nerve from the distal humerus all the way through the forearm. So this is the avian process, or supracondylar process, which we can see right here. The ligamentum of Struthers would be right in through here, and the median nerve will go right in, right by the base of it there. Here's an MR scan of this, and it's a little bit subtle. There's also a vessel that goes through that area as well as the nerve. This is actually the process right there on the sagittal images. On the axial images, we can see it here, and you can see the nerve, artery, and vein going right along the avian process underneath the ligament of Struthers in this location. Okay. I forgot who's next. Okay. So here's an elderly female with median nerve palsy.
So median nerve palsy 1 month after a coronary angiogram. So it looks like we have some ultrasound images of the brachial artery, and there's atherosclerosis and okay, so outpouching of the vessel with the neck. So this is going to be a pseudoaneurysm of the brachial artery. Yeah, probably where they entered in for the angiogram.
Producing the symptoms. So we then move a little bit more distally. We've got the pronator muscle, nerve entrapped at the level of the pronator teres when it goes by right in through here. You get pain and numbness, and also you typically get edema in the pronator teres muscle. So this is kind of an example of what you get. It's very hard to see the nerve, typically with MR in this location. You actually make the diagnosis of the disease not by seeing the lesion in the nerve, but by seeing the distribution of the muscle edema and the distribution of where the nerve innervates the muscles, as we're used to in other areas as well. So this is the typical pattern of the pronator syndrome. Okay. Michael?
61-year-old BART clerk with elbow form, wrist pain, and dysfunction of the thumb and index finger. So I see some edema along one of the kind of flexor, is that the flexor digitorum superficialis, kind of down the anterior aspect of it.
So the pronator is going to be more anterior.
Yeah.
So we see that. Here are the axial images.
And so we see edema running down that muscle, kind of it's like compartmentalized. And I can't really see from here where the nerve would be.
Yeah, so it's hard to see the nerve in this location.
But
what we can see is the innervation effects of the flexor digitorum superficialis and the flexor digitorum profundus muscle in these locations with severe atrophy of the flexor digitorum superficialis. So you have to be concerned about whatever innervates that muscle, or I guess it could be a chronic tear. So you have to look at the proximal and distal insertions, but they were intact here. And then if you look more distally, what are we seeing here?
What would that be? A branch of the nerve, John?
Yes.
So more distally, I mean, are we just seeing kind of this like supinator atrophy? Or pronator, no, it's not supinator, pronator quadratus.
And atrophy in the pronator quadratus. These are the muscles that the median nerve innervates. So, and then here, you go down to the thumb, it's also the thenar muscles are innervated by it. And this is a typical appearance that you see with the pronator syndrome. So this would be some compression or neuropathy really at the level of the pronator of the median nerve when it comes down. So this distribution helps you pinpoint the location. And this is again fairly proximal at this potential. Then if we go more distally, we get to the anterior interosseous nerve syndrome, which is a more distal involvement. It's usually from direct trauma. And here you get progressive thumb weakness typically without numbness. But the pronator, the more proximal muscles tend to not be involved with this. And my first father-in-law used to work out in the oil fields, and he got his forearm severely crushed one time by pipes and over the next couple of years, he actually started losing function of his hand, and his thumb kind of curled in, and he saw many different doctors, and finally he saw a hand specialist in Dallas, one of many that he saw, who made this diagnosis just clinically, and then operated in this area, and he found the scar tissue, removed the scar tissue, and it completely resolved. So it was pretty dramatic for him. So this is the interosseous syndrome. The typical appearance you see here is edema of the flexor pollicis and the digitorum muscles down here, and also the quadratus down here, not the more proximal muscles, as you would expect, because it's a more distal lesion. And the typical appearance really is a thumb weakness on physical examination. And I usually see this about once a year. And then here showing some of this one actually goes a little proximal. This would be kind of between the pronator and the anterior interosseous type. This is the flexor pollicis longus. Okay. Let's see. Ashu, what do you think of this case?
48-year-old with limited pronation. You can see here there's increased signal within that muscle. I think that's going to be pronator teres.
Yep, that's right.
And so, yeah, you're worried about a median nerve injury or compression.
The median nerve in this area here. Okay. And here again, we can see the very well-defined muscle edema, looking like a denervation syndrome. And this just shows where the nerves are located and the different muscles that can be involved. And then this is where you go through the pronator in this location, and the interosseous would be a little bit more distal to that. Yeah. And then these are the typical muscles involved. Really, the flexor muscles are involved with the median nerve innervation, and then basically the more distal the lesion, the less involved the more proximal muscles are. Yeah, we'll have another lecture on nerves to talk about what axonomesis and some of the different terms are later lecture. And then let's go to the radial side, the radial nerve. Here you can get the posterior interosseous nerve syndrome. It's also called the radial nerve syndrome, the supranator syndrome, and the radial tunnel syndrome with multiple names. But that's more on the lateral aspect of the elbow in this location. And as you can tell, the radial nerve actually supplies the supranator muscle. So radial tunnel syndrome, you get compression and entrapment of the posterior interosseous deep branch of the nerve. You get pain in the lateral forearm, and then you get denervation atrophy of more the supinator and extensor muscles, not the flexor muscles. Posterior interosseous or PEN syndrome. Here the radial nerve comes down over here on the lateral aspect anteriorly, and then it divides into the posterior interosseous, which comes down through the extensor muscles, and then also an anterior branch, which then goes in the region of the arcade of Frosch, right in here. Now, this is the posterior interosseous nerve. This arcade here is a fibrous band of muscle tissues associated with the extensor muscles, which can be a very sharp interface that the posterior interosseous nerve has to go through, and this is an area where you can get compromise of the posterior interosseous nerve.
Is that really showing the frosh?
Well, it would be this thing right in here. I think I've got better images elsewhere of that.
That I don't. That's. I'm not sure that that's showing it well.
I think you're right, John.
Sorry, I have to step up real quick. I'll be back.
The classic findings is really, this is more, some of the others are more weakness. The radial tunnel syndrome, or the PIN, is more of a pain syndrome when it presents, and it presents here on the radial side, the lateral side of the forearm. Okay. Now, there are a number of branches that come off the nerve that can also be either damaged by trauma or irritated. And one is the lateral antebrachial cutaneous nerve entrapment. Yeah, you can forget this after I said it. The only thing with this is this can produce skin pain and pain on the lateral side of the forearm, and it's occasionally seen in throwing athletes due to injuries to the distal biceps tendon, where this can be injured with the distal biceps.
Campbell's says don't worry about sensation with the radial nerve.
Okay. Yeah, it's pain. It's mostly a pain finding. Yeah. And then this is probably a better view, John, of the
Yeah, I agree. It's now I can see it.
So here's the radial nerve coming down through here. It divides into the posterior, and this branch, the posterior interosseous nerve, and then the anterior branch right there. And the posterior interosseous nerve comes down, and this is the arcata frosh, which, as you can see, is the proximal edge of the supranator tendon in this location. And this is a typical area where it can get compressed with trauma, right around the supinator muscle here.
Yeah. Yeah.
And then here you get the superficial branch coming out here. So that's where we look for it. Okay, Jennifer.
Just to let the fellows know, John, I left a book on the shelf there for you by a guy named Skinner, and he wrote a book on the forearm and the nerve injuries, and that's the only book I know of that was written strictly for that purpose.
Thank you.
He was a very bright guy.
Yeah, thank you. We appreciate that.
You're very welcome. I never learned that book too well, but because hand surgeons loved it.
Mm-hmm. Yep. All right, so here we have a case of a 26-year-old male with radial head pain and thumb extension limitation, and it looks like here that there is some preferential atrophy of the supinator muscle and maybe some edema, so I'd be concerned about compression of the posterior interosseous nerve. Yeah, so here again we see some atrophy and edema. Yeah.
So this patient had the abnormality of the supinator. So it could be a muscle strain, or it could be a denervation from a nerve injury. In this particular case, it was a nerve injury. Okay, and then here we go. Here's the superficial radial nerve there. Here's the posterior interosseous nerve right back in through here. Here we can see the edema within the supranator muscle in that location. And then you can see some of the other anatomy there. And generally in this area, it's very, I'm not sure I've ever seen it. You really have not been able to actually see the injury to the nerve. Maybe other people have been able to describe it and see it. You just use the clinical findings and the MR muscle findings to kind of make the diagnosis. Another example, the artery also goes in this area. So this would be the arcata frosh in this area around the radial head. And again, we can see the abnormal supinator muscle in the branches.
You best see the radial nerve when it wraps around the distal humerus. Yeah. And that's the nerve that's injured when the humerus is fractured distally. And many times it'll just come, the function will come back, even though you have a drop wrist from the injury, but the function of the nerve most frequently does come back. It's just a stretch injury or a contusion from the fractured spikes of the bone.
So here they define radial tunnel syndrome as a pain syndrome, and the posterior interosseous nerve syndrome is a motor neuropathy. So
that's in a forearm, isn't it?
that's in the forearm, right?
Yeah.
So, what do you think about this guy, Michael?
Recent onset forearm mass and weakness. Ultrasound.
So that's the.
It says left supinator long and left PAN.
So you get nice resolution there, but I think the pathology is a lot easier to see. And here's the other.
Oh, okay. I mean, so there's a lot of, fluid within the supinator muscle, like almost kind of completely.
What is this? This is T1 weighted image.
Oh, this is T1 weighted image. Oh, so then this was.
This is the nerve.
Yeah. So that's T1. That could be, if it's T1 bright, then it could be hematoma.
It could be, but it's not. It's more likely because.
Then a big lipoma.
So that's a big lipoma. And there's the nerve. And it's compressing the nerve right in the area of the lipoma. And here we can see the fat suppressed images showing the lipoma here, and the nerve was draped over it. And this patient had a posterior interosseous nerve syndrome. Okay. Ashu, you back with us yet?
Yes.
Okay. Why don't you take this case?
All right. So 58-year-old woman with a motor deficit. On these fluid sensitive sequences, it looks like there's some fluid, I'm guessing in the region of the supinator. Although it looks like, it looks like fluid, almost like there's septations. It could be a lipoma though.
Well, this is a fat suppressed image.
Oh, this is, I'm sorry. Yeah, sorry.
Lipoma is
Yeah.
sarcoma.
Yeah, no.
It could be a myxoma though. And here we go down. Maybe a little bit of atrophy of the supinator. But what do you think is most likely going to cause a fluid in this location?
Either a tear or a ganglion. Okay.
And this patient had pin syndrome because of its location. It also compressed the motor distribution of the pin, and the patient had marked weakness of the thumb, abduction of the thumb due to that. Okay.
All right. So this is a 5-year-old male. We have some sagittal and AP views of the elbow, and it looks like there is a minimally displaced fracture of the proximal ulna, and there's some dislocation of the radial head. Yep, Montasia. So I guess. Yep.
Montagia fracture.
So here's after the reduction.
Okay. So now the normal radial head's normally located, but he has failure of finger extension. So yeah, I'd be concerned. Yes, get an MR. Okay, so I think this is a branch of it's the posterior interosseous branch of the radial nerve, and here we can see it coming down here along the radial head, and there's some edema in the supinator muscle, and also in some of the other muscles, edema and fluid. Yeah, I don't see that posterior interosseous branch as well, so I'm concerned. I guess from all the swelling, there could be some impingement of the nerve. I would think this might go down once the swelling improves. Mhm.
So let me just distally show this.
Okay. Traumatic swelling of the supinator.
Acute denervation.
Okay. Acute denervation. Yeah. So I would think this would probably just go away on its own once the swelling goes down.
John, do you think that's correct, what Jennifer just said?
I missed it, John.
Oh, she says that she thinks that this will all get better once the swelling goes down.
Yes,
Okay, good.
I certainly agree, but it may not come back within a day or two. It may take a week or two, but you don't give up on these.
Okay, and then this just shows that you certainly have to be concerned about whether you had a complete transection of the nerve. So I think you would have to do nerve studies to do that. Some places might experimentally try to do
There's no harm in waiting. The reason being is that a child, and doing nerve conduction studies are okay, but when you start sticking needles into the muscles, that's something else.
okay.
That's not okay.
Yeah.
Because that's painful.
Yeah.
And you don't get much out of it. All you have to do is wait. There's no harm in waiting.
Okay, so we see, I guess, edema within the supinator muscle. All throughout there. Is there a history of trauma, or?
Yes.
So this could be acute, could be similar to the other one where they have a lot of edema and swelling, which could compress the radial nerve versus direct injury to it. Not sure.
I don't remember exactly on this one, but it was a patient that had radial tunnel syndrome. And I think this is primarily pain in this particular patient. Okay, Ashu?
So this patient has a wrist drop for several weeks. I'm just looking here. It seems like there's a lot of signal centrally there. Oh no, I guess along the there's mild increased signal along the extensor tendon there. Yeah.
The muscle here, right?
ECRB or?
Yeah. And this patient had wrist drop. That's right. Yeah. And there we can see the muscle along it there. And then if we go to the axial images, this is the extensor digitorum and the extensor carpi ulnaris here, these two. And then this was an injury to the medial branch of the posterior interosseous nerve in this location. And the other, yeah, so, right. So the posterior interosseous nerve syndrome, the typical findings for the motor part are edema within the extensor of muscles, which we can see back here. Okay.
42-year-old female with slow progressive limitation of extension at the right first through fifth fingers for 1 year. Previously undergone surgery and chemotherapy for breast cancer 6 years ago. Okay, so we can just see diffuse fatty atrophy of the extensor muscles and kind of extending all the way to the distal forearm. Extensor pollicis longus, indices, and digiti, and no prior surgery, hemorrhage, or mass lesion. So I think this can be the result of chemotherapy. She also had surgery.
You'd have to worry about scarring.
So this patient, this is another posterior interosseous nerve syndrome involving a lot of muscles here.
I guess this can occur, neuropathy from chemotherapy.
That wouldn't be just a single nerve.
Right.
So I don't know where the surgery was. Was it the breast surgery, or are they talking about the nerve decompression?
Breast surgery.
That's from the forearm.
Yeah, so I don't think that would cause specifically that nerve syndrome.
That nerve is not all that big. And it can be injured pretty easy. Sometimes all you do is put a retractor on it, and it'll go poof. See, it's a muscular nerve.
Maybe if she has a lot of swelling after mastectomy, but it's still weird. It just has involved that one nerve.
So here.
No, it wouldn't catch just one nerve, as far as I know.
Here are the findings that they saw in this set of 25 patients. The most common finding was isolated edema of the supinator muscle, and then you can have scattered single other muscle involvement. The most number of patients who actually had posterior interosseous nerve denervation actually had a normal MR scan. So we're not very sensitive. Again, this is the kind of edema you're looking for.
Yeah.
So why don't we stop here, and we'll start talking about inflammatory disease of the elbow next week. Okay, any questions? All righty.
Have a great